Good evening, everybody. I hope you've all had a good day and welcome to our Zoom webinar this evening entitled Enhancing Early Detection, the Latest in Cancer Screening. My name is Phil Flanagan. I'm a Program Officer working on quality improvement initiatives and also some health reform work at the Northwest Melbourne Primary Health Network. And I'll be co-hosting this session this evening with my colleague Hannah Saunders, who's the Clinical Education Manager at the Australian Centre for the Prevention of Cervical Cancer. And we'll introduce Hannah later, and she'll be hosting the second part of this evening around the Q&A session. So as we start this evening, I'd like to, on behalf of Northwest Melbourne Primary Health Network, acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Bunurong people, and the Wathaurong people. I'd like to pay my respects to elders past, present, and emerging, and to also pay my respects to any Aboriginal and Torres Strait Islander people who may be joining us in this session this evening. Thank you. This evening's webinar is actually brought to you as part of the Victorian Cancer Screening Framework Initiative. And the partners in the Framework Initiative are the Australian Centre for the Prevention of Cervical Cancer, the Cancer Council, the Victorian and Tasmanian Primary Health Network Alliance, VIPNA, and Northwest Melbourne PHN is a member of that alliance. And may we also acknowledge the Victorian State Government who've supported the delivery of this webinar this evening. So as we know, we're on a Zoom webinar. I'm sure we're all very familiar with them these days. As an attendee, you will be muted, so please bear that in mind. One of the things we really strongly encourage this evening, because we have a fantastic panel of speakers, is asking questions via the Q&A box. And please may I emphasize that the questions are best to come in through the Q&A box only. We do have time for a session later on this evening, which will be facilitated by Hannah with our panel members. And we'd probably prefer to take most questions via the Q&A box, but if you have something which is maybe earth-shattering, can be dealt with quickly, the presenters are flexible to take a question on notice during part of their presentation. The session is also being recorded this evening, and I can assure you that you will receive a link to the recording and a copy of the slides following the session via an email. We will also have an evaluation survey at the end of the session tonight, and we'd really strongly encourage you to click on the QR code and to partake in the evaluation survey, please. The other thing that's very important to point out tonight in terms of general housekeeping is to note that you have joined the session using the same name as the event registration that you originally registered for this evening with. Also, likewise, if you've actually phoned in, can you make sure that your phone number is the same one that you've dialed in with this evening? This is important because Northwest Melbourne PHN uses the Zoom participant list to mark attendance and to issue certificates following the event. And unfortunately, if we can't match up the details of your good selves either via your phone or your name messaging, then we won't be able to issue any CPD certificates. If you're unsure whether your name matches, please just send us a note in the Northwest Melbourne Education chat box. Thank you. And finally, it's with great pleasure that I can introduce our fantastic panel of speakers this evening. Firstly, if I may introduce Professor Marianne Saville AO. Professor Saville is an anatomical pathologist and has been Executive Director of the Australian Centre for the Prevention of Cervical Cancer since 2000. Marianne currently chairs the working group to review Australia's guidelines for the management of screen-detected abnormalities in the National Cervical Screening Program. And Marianne was appointed a member of the Order of Australia on Australia Day 2020. And that was for her significant services to women's health through cervical screening initiatives. So welcome, Professor Saville. May I also introduce this evening Mr. John Lee from Telstra Health. John is the Head of Engagement and Communications for the National Cancer Screening Register at Telstra Health. He joined the team in 2018, bringing over 10 years experience in the field of cancer screening, health promotion and engagement in both the UK and Australia. John is passionate about improving participation in cancer screening programs and integrating the broader healthcare ecosystem to help improve outcomes for Australians. Welcome, John. And finally, I'd also like to welcome Professor Justin Zay from the University of Melbourne. Justin is a practicing general practitioner at Doctors of Ivanhoe and an academic specialist in the Department of General Practice and Primary Care at the University of Melbourne. He also holds appointments with the Victorian Comprehensive Cancer Centre and Cancer Council Victoria. Justin completed his research degree in prostate cancer and is involved in research with the Cancer in Primary Care team at the University of Melbourne. He has a specific focus on bowel cancer screening, prevention, and early detection. So welcome to Professor Zay as well. And without any further ado, I think I'll hand over to our first speaker, Professor Saville.
Thank you very much for the kind introduction. Just share my screen and hope that everyone can see that in full screen. I would like to add my respects to Aboriginal and Torres Strait Islander elders, past and present, and of course extend that respect to any Aboriginal and Torres Strait Islander people who are attending the webinar today. So just starting with some contextual comments, and then I'm really going to talk about updates to the cervical screening guidelines in the main body of my talk. Of course, at the end of 2017, we switched our program, so we commenced screening, or we want screening to commence at the age of 25 with a 5-yearly interval and an exit test between the ages of 70 and 74. As you know now, we use a primary HPV test with partial genotyping that enables us in the lab to detect those types 16 and 18 that are most oncogenic and responsible for about 70% of all cervical cancers. And of course, those are the types that were included in our first vaccine, the Gardasil vaccine, back when that started around 2008. We've learned a lot about the accuracy of self-collection since the program started, and I'm not going to go into that tonight, but we have very good evidence about the accuracy of self-collection for the detection of HPV when it's associated with precancerous abnormalities. And of course, that is now an option, or should be an option, for everyone presenting for screening, whether they would like to have a clinician-collected sample from the cervix with a speculum exam, or to collect using a swab. And of course, screening is for all sexually active women and people with a cervix. And when we say sexually active, it's people who've ever been sexually active, because of course we know the biology of this disease is such that HPV can remain latent in the cervix over many years and even decades. Of course, when we switched from our old PAP program to the new renewed program, we commenced invitations to screen from the National Cancer Screening Register. This had not been a feature of our previous program, and reminders to screen and follow up, as you'll be aware, continue to be operated through the National Register. And so this expanded cervical screening option went live almost 3 years ago now, in mid-2022. And as I've said before, participants should have the option of screening whichever way suits them. And it's important that people presenting, particularly those responding to the national campaign, the Own It campaign, which is community facing, are met with an understanding of what self-collection is about if they present to you for screening. And we're very happy to provide further information about all of that should people want it. As I've said, we know self-collection is accurate, and the breakthrough was the 2018 meta-analysis that showed us that it had identical sensitivity for the detection of high-grade disease as clinician-collected samples, provided a PCR test is used. And of course, by regulation, laboratory regulation in Australia, all labs must use a PCR assay if processing self-collected samples. The added cellularity control gives us that safety that if patients haven't collected the sample, if they've opened and closed the swabs, which sometimes happens, we'll get an invalid result. We know it's easy to do, although we also know that sometimes patients think it's going to be trickier than it is. And we know it's incredibly acceptable, particularly to people that we haven't been able to reach with our screening program previously. And here you can see data from the National Cancer Screening Register showing you that since that went live, a very high proportion of Australians participating in cervical screening are now accessing self-collection. and it is becoming an important part of our program. We also know that the people accessing self-collection are more likely to be underscreened, never screened, living away from metropolitan cities and coming from our socioeconomic quintiles that are most disadvantaged. So these are all groups that we've wanted to be able to reach. But what I really want to spend the majority of the time on is just updating you on some new changes to the cervical screening guidelines, and to walk you through these. You'll see that the screening guidelines are now going to be on the Magic App platform, which many guidelines are now presented in. I'll say more about that. So we're using the Magic App platform. We hope this will be a more user-friendly experience. There is a new chapter in the guidelines about cervical screening in practice, which I'll say more about. Excitingly, there are changes to the post-treatment management for people with squamous high-grade disease, which means that self-collection will be an option open to them. The categories of people considered immunodeficient and requiring more intensive screening and follow-up have been expanded. And we have now a strategy for people who've used self-collection but haven't represented for a clinician-collected sample in a timely fashion. And I'm going to say something about screening after total hysterectomy. This has been largely simplified to annual testing, and changes to surveillance following treatment for adenocarcinoma in situ. So firstly, we now are moving from the old wiki platform across to the Magic App platform. As I said, it is an improved structure and format to support ease of navigation for people who are accessing them. And essentially, and importantly, what it really does is it brings what you need to know up to the front, and then you can drill down and look at the evidence if that's what you want to do. But in our old way of doing things, the evidence review came first, and then the conclusion was the clinical recommendation, and appreciating that not everyone has time for this. My tip for using the Magic App platform is that there are now many guidelines on that platform. And if you get yourself a login, when you log in, you can look at my guidelines, and then you'll just see the guidelines that you want to have on hand when you're in Magic App. All recommendations, good practice statements, and decision flow charts, as I've said, are displayed on the front page of each chapter. So you should see what is needed to be done as you come in, and we hope that will be a better experience for people accessing the guidelines. This new chapter on cervical screening in clinical practice was very heavily led by Professor Deborah Bateson, a primary care practitioner, not a GP, she reminds me, and she's very active in the sexual and reproductive health space. And this chapter brings together in one location the important concepts that are really for GPs and other people in the primary care sector. It also has links to specific sections and to various toolkits. So you see here on the right-hand side a very high-level overview of what's in that chapter, not only understanding HPV and its role, but suggestions about how to explain this complicated biology to your patients when that's necessary, a little bit about the program and the register, quite an extensive amount about supporting informed choice between clinician-collected and self-collected screening, and supporting participation of under and never screened people. And you'll see there with 5.6 that there's an arrow and there's particular suggestions for particular priority populations. And so you see the rest of those contents there. So screening people with immune deficiency, of course, we define immune deficiency as either severe, as acquired or congenital immune deficiency, to wrap them up together. Of course, most people have acquired immune deficiency. And most evidence in this space relates to transplant patients and people living with HIV. And it's a very, very difficult space to get the evidence around. However, and I'll talk more about who we consider to be immune deficient for these purposes in the next slide. Of course, the important thing to remind you is that if the patient is immune deficient, they are assessed at being at substantially increased risk of cervical cancer. They should be screened more frequently, so every 3 years, and they should be referred for colposcopic follow-up in a tertiary centre if HPV of any type is detected. So even if it's a non-16/18 and even if there isn't high-grade cytology reflex, these patients need to be seen because not only they're more likely to acquire HPV infections, but the pathway to precancerous abnormalities and cancers is shortened. So we want to be on top of HPV infections in these patients. This is a very challenging area of the guidelines because particularly with the pharmaceutical agents that cause immunosuppression, it's a fast-moving area. So on the left, you see the people that we would definitely consider would require 3-yearly screening. And on the right, those in whom we would highly consider that more frequent screening. And we have tried very hard and worked with immunologists. But I think the advice really is, if in doubt, please talk to the prescriber, the specialist prescriber of some of these novel immunosuppressive therapies, because it's just not possible for the cervical screening guidelines to keep up to date with this in real time, and it is a very dynamic space. I'm sure you'll all be aware of that. I'm excited about this change. So changes to the test of cure. Currently, patients who've had biopsy-confirmed high-grade abnormalities, squamous, so that's CIN 2 or 3, patients with these abnormalities, even once treated, we know from our old program, remain at elevated risk of cervical cancer for decades. However, evidence is very clear that we can separate this group into those in whom we don't have evidence of HPV and those in whom post-treatment and those in whom that persists or recurs. And so the evidence shows us that following either a co-test or an HPV test that's been negative twice with 1 year in separation after treatment, those patients are actually at baseline community risk and can return to routine screening. So test of cure now that we have the evidence around using just an HPV test rather than a co-test, test of cure as of the 14th of April will be 2 HPV tests a year apart, and then considered baseline and back to 5-yearly screening. So this then means that patients who are in a test of cure pathway can access self-collection, and that I think will be a really good advance for some patients who still don't want a pelvic exam in that setting, and also because we have found that since test of cure, self-collection went live, there are patients that are presenting for screening. Their GP is screening them. However, it hasn't been realised that they have a previous history of high-grade disease, so then we have to call back and ask for the cytology to be collected. So with this new evidence, this can now be undertaken with just HPV tests. And if we detect HPV in this test of cure process, we will refer patients back to colposcopy if the HPV is type 16 or 18, or if they have other types, but high-grade cytology has been detected on a reflex test if a cervical sample is available. Otherwise, patients continue to test annually, and in the absence of high-grade disease or HPV 16 or 18, they would only be referred back to colposcopy if the non-16/18 persists across 3 annual tests. So turning to patients who have self-collection, these are patients who have HPV types other than 16 or 18 detected on self-collection. They're asked to come back within 6 weeks for a clinician-collected sample that can be used for LBC, so that we can triage whether they need immediate referral to colposcopy or whether they should come back in a year. So here we're talking about patients here in the pathway. They have a non-16/18. We've asked them to come back to for a clinician-collected sample, but they haven't. And we're back to very closely within a year. And so at this point, they can again access self-collection because we can't go back in time and give them that immediate colposcopy. What we need to know at this point is whether the non-1618 has cleared or whether it persists. So for those who do not return, and 9 months is just the threshold we use that they're so close to the 1 year test that we consider them for practical purposes to be at 1 year. At that point, you can offer them a self-collection to see if that HPV is still there. So here's a case study. We're going to run a little poll on this. This is a patient who has a self-collected sample. She is under-screened. Her results have come back non-1618. What is the appropriate follow-up when she returns to see you? Must an LBC be taken, or can she collect her own sample again at 10 months? So we can see that poll running. And I think the responses are slowing down. And so I think the majority have it. So can we take the poll down? Can the participants see that poll now? Sorry. Can we take the poll down now?
Is it still showing?
Yeah, it is. Or maybe I'll just click forward and see what happens. And so, of course, the vast majority of you have answered this correctly. No, I can't continue.
Give me a sec. Sorry.
That's all right.
You might just need to shut down the poll window, Marion. Just click on the close.
Where it says back, maybe. Oh.
Is it?
I don't have a window.
It's ended. It's ended on my end. Apologies. Hang on. Can you move? Can everyone see the screen now? Not the slides.
No, but
because I can see the slides.
Can you? Is it if it's just? I'm having trouble seeing my own slides, so that's the problem. It's down across them. So it's ended. So apologies for that. Almost all of you answered that correctly. And at 10 months, Samia can collect her own sample again. So that's great. Screening after hysterectomy has been simplified to annual testing, which is a co-test or an HPV test, depending on the patient's history and the findings at hysterectomy. And that testing happens, on 2 occasions until on both occasions consecutively the tests have been negative. We have, I hope, simplified the horrific flowchart on the left to something I hope is more manageable on the right. And so the considerations are, well, firstly to say that this is, of course, total hysterectomy, and patients who've had a subtotal hysterectomy need to screen as patients who haven't had a hysterectomy, although those operations are becoming far less common these days. The considerations are the screening history prior to hysterectomy and the findings at hysterectomy. And so here is the revised flowchart. And firstly, for the vast majority of people, if they participate in the screening program at all and either had no evidence of in situ disease, or if they've had squamous disease and completed test of cure, And if there's no pathological findings in the cervix at hysterectomy, those patients don't need any further follow-up. And this is, as I said, the vast majority of participants. Those who are still in testicure, so it hasn't been completed, those who have cervical disease at hysterectomy, and those who have never been screened or they have an unknown screening history will have annual HPV test until 2 are negative on consecutive occasions. And finally, for those who have had adenocarcinoma in situ, this is a very small number of patients, which I'm sure you all know. These patients now have an annual co-test, and provided they've had hysterectomy, so this is not excision for AIS, they can now cease when 2 co-tests are negative on 2 occasions, remembering that all patients with adenocarcinoma in situ prior to the new guidelines going live were getting annual co-tests for life. So that's, I think, a really big win for some of these patients, many of whom are getting past the age of screening and still being asked to have those annual exams. There's also been a careful and slow de-intensification to surveillance for those patients who have been treated for adenocarcinoma in situ, but have had excisional treatment, so they still have their cervix. And these patients currently require annual co-tests for life, and we weren't really sure when we could pull back from that. But looking at overseas trends and evidence, we're now able to extend the interval to 3 yearly co-tests, so a cervical exam, if all co-tests have been negative for 5 years. And if we get all tests negative at 25 years, patients can then return to routine screening if they're still of screening age, or exit the program if they're older than screening age. In practical terms, we've only been using co-tests for test of cure and HPV set tests since 2006. So we won't have patients in that last bucket until 2031. Where we do find any abnormality at all in these co-tests, these patients should be referred straight back to colposcopy because of the difficulty of making a diagnosis or detecting glandular disease when it's there, and the risk of adenocarcinoma invasive. I just finally want to talk to you about one more change to the guidelines, and this is in relation to, it's a colposcopy change, but it might affect some of your patients. So patients who have had colposcopy and in whom we haven't found any disease, and particularly those with HPV 16 or 18, they have a follow-up HPV test at 12 months, and those with 16-18 are referred back to colposcopy on an annual basis while the 16-18 persists. For some patients, and particularly older patients, that has become problematic. It has been agreed that patients who have had LBC after that, and the HPV and the LBC is negative, the test could be repeated in 12 months before re-referral to colposcopy. So this is an option that colposcopists will discuss with patients, and it's going to require communication through the register and directly with you as the referring GP. So that's an area where I think the guidelines are responding to some challenges, and this will require careful communication on a case-by-case basis. So there is this option to re-refer for an LBC. Labs will be making the recommendation to go back to colposcopy, and there will be communication between labs, colposcopists, and the NCSR. So there are resources available for you in relation to changes to the guidelines. They're available here. And of course, you'll have access to this link and the QR code. And they're available. There are a whole suite of resources available to you on the ACPCC website, many new and updated resources. And the Cancer Council hosts a range of resources that are really designed more for patients to explain what's going on and to support them. So please don't hesitate to contact us if you need any help. And thank you for your time and attention.
Many thanks indeed, Professor Saville. That was a fantastic overview of the changes to the guidelines for cervical cancer screening. So thank you very much indeed for that presentation. I know we've had a question come in through the Q&A, so just a friendly reminder to everyone, please submit your questions via the Q&A box. We do have some time for some questions later on after our presenters this evening. And without any further ado, I'd like to hand over now to Associate Professor Justin Zay from the University of Melbourne. Thanks, Justin.
Thank you, Phil, and thank you, Marion, for a wonderful presentation on the cervical cancer screening program. I'll just get my slides up and just bear with me. Can everyone see that? So before I begin, we acknowledge the Wurundjeri people who are the traditional custodians of the land on which we meet today, and acknowledge and pay our respects to their elders past and present. We acknowledge those who are meeting on other First Nation lands and pay respect to their elders past and present. I've got two parts to my presentation. I'll be talking for the first few minutes on health pathways. And then the second part will be a more intensive look at some changes in the National Bowel Cancer Screening Program, but also some practical tips for clinicians, GPs, primary care managers and allied health to look at what they can do to promote cancer screening in our community. So this is just a little bit about health pathways, and they're written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. It's clear and concise, it's evidence-based, and really a good tool for us to utilise information for the best outcomes for our patients. One fundamental key to health pathways is to reduce the variation in care. More importantly, how to refer to the most appropriate hospital, community health service or allied health providers. And for those who are new to the area, it's a really good resource to see what service is available. But also as an active GP myself, I've been in my location for 25 years. Changes occur to services, and health pathways is a good resource to look at what those new changes are. So this is the landing page for health pathways. A really cool and key tool is the search right at the top. And as you can see, if you type in cervical screening on the left-hand side, immediately it'll bear down to cervical screening. And you can see there's a number of headings: women's health, then drills down to gynecology, and cervical screening then comes up. And you click on the link and then you come to the information you need. So this is the cervical screening. There's two. There's one for national bowel cancer and cervical screening as well. For the left-hand side with the cervical screen, you can see the red flags, assessment, practice points, and that's key information that is highlighted for the user to note. With the first green arrow, it gives you some tips on history, what is required on the history when taking a cervical screening consultation. It's also mentioned the need to look at the National Cancer Registry, and I'll be demonstrating some of that through the next few slides on the National Bowel Cancer Screening Program. Also, point number 4, and that's the second green arrow. There's check the routine screening recommendations, and you click on that link and more information will come down. And also we'll give you information about additional screening recommendations for specific patient populations and whether also to consider STD testing. A clinical note, the fact that health pathways has already stole my thunder for my talk, the fact that there has been a change from last year. The age from screening is now from 45, not 50. So that's a huge change for us in how we apply this to our patients in the community. This is a busy slide. Let's just say the health pathway is comprehensive, and this is just looking at cervical cancer and other obstetric and gynecological conditions. With the bowel cancer screening program, lots of key web links in the health pathways platform, not looking at the bowel cancer screening program, but also what happens when a patient has a positive fecal occult blood test, what to do if there are gastrointestinal investigations to look for symptoms, and then referral pathways, urgent or non-urgent. Finally, just on the bottom left, you can see some specialist criteria for referral to our specialist outpatient clinics. One of the things that all of you know as clinicians is that if you don't put all information, a referral may be rejected. So again, Health Pathways can really assist in this way. One of the new innovations for Health Pathways is CPD hours for Health Pathways use. So if you do search, and you can see just on the top, if you type in CPD, automatically on the left-hand side, you'll see the left green arrow, which says CPD hours for Health Pathways use. And as you can see, this is the web site. It links in with all the college programs, and particularly with the RACGP and ACRIM. If you do click on the right arrow, which is to create a CPT report, there's some activities that you'll need to do, and half hour for reflective practice, and then half hour education activity, which is reviewing the information on Health Pathways. And then through the templates offered through Health Pathways, you'll be able to submit through the link to gain your CPD points. So one can scan this QR code to register. It does take a few days to be approved. Obviously, if you want to sign in and got an account, the website comes up through this QR code. If you're used to using Google search, just put Melbourne Health Pathways and it'll actually guide you to the same link. So to the National Bowel Cancer Screening, I was given two objectives to really go through for this evening. And the first objective is to identify changes to the National Bowel Cancer Screening Program guidelines and them supporting them. And the objective two was discuss changes required in clinical practice as a result of bowel screening guideline updates. There'll be some technical aspects. I'm really pleased that John is here just to help me also with cancer registry and the role of medical records, and also how we can access it through our website, through the PROTA website. So a little bit of background and context. This is Cancer in Australia, 5-year survival rates. And as you can see, colorectal is 68%. This was back in 2013. What's a key highlight now at 2023 or 2023, our overall 5-year survival rate now at bowel cancer is 73%. And what is really pleasing is in 2023, if diagnosed at stage 1, the survival rate of 5 years is 90%. And that's very different to when I went through medical school, where the rates were at stage 1 around the 60 to 65% mark. This is just looking at living with cancer. You'll see if in these slides, and I'm sure you'll get a copy of these slides, if you see the link, this is where I've actually hyperlinked to all relevant information for people to use. But this is from the registry report from the Cancer Council Victoria in 2022. And it looks at living with cancer and relative survival rates, and they're really high for breast, prostate, melanoma, and bowel cancer. And what you can see is with bowel cancer, at stage 1 at diagnosis, it's 90%. And this is looking at relative survival rates. And what we mean by relative survival rates, it takes into other factors like SES status, improved healthcare access, and lifestyle changes post-diagnosis that can enhance survival rates. So it's a multi-factored relative survival rate that gives an indication that bowel cancer, if picked up early, can make a huge difference to 5-year and survival rates. Just quickly before we look at the now National Bowel Cancer Screening Program, I want to just highlight with symptomatic patients the fact that screening programs are for asymptomatic patients. And if you do have patients with symptoms and signs, please look through the optimal care pathways. Look, for me, this is just a simple summary that looks at the stage or step 2 when someone presents with symptoms or signs. It entails a detailed history. Family history is also required, taking a physical examination and undertaking a digital rectal exam, considering some initial blood testing. And this includes a full blood examination and iron studies. Then it's up to you as the GP to decide on the right path. And with discussion with the patient about what services needed, whether they go private or public, possible costs and timelines, and whether in terms of judging on the symptoms, the signs, any red flag symptoms, you may decide to refer to a specialist straight away. Or in turn, you might decide not to refer to a specialist, but organise a colonoscopy given the risk or the concerns you have with the patient. Being also part of the college, we have the Red Book. The Red Book is a fantastic resource. And just flagging, this is what the college recommends for colorectal cancer and screening. It recommends immunochemical fecal occult blood testing every 2 years, starting at the age of 45 and continuing to 74 years for those with average risk of colorectal cancer. We also have generally not recommended is the colonoscopy is not generally recommended for screening people with average or slightly increased risk according to their family history. So that's from the Red Book from the college. So the National Bowel Cancer Screening, and really the essence of today's or tonight's presentation. Many of you who are interested in history, this program started in 2006, and remember it started with the 55 to 60 age group. And in 2014, we were able then to cover the 50 to 74-year-old age group. In 2024, as highlighted by Health Pathways, is the practice point with the clinical editors note, the new age is now 45 to 74. So we now include additional 4 years. What's the rationale? The evidence that really the early detection improves 5-year survival rates. It's a safe, reliable test, and it's easy to use. The fecal occult blood test can reduce deaths from disease by 36%. Unfortunately, the uptake is still low at 40%, and this is indeed the lowest out of the 3 national screening programs. I think breast is, or mammography is around 50%, while I believe cervical screening test is at the 65-70%. So, bowel cancer screening program still has a way to go to increasing participation rates, and that's why all of you in primary care have a crucial role. This is from the Cancer Council, just looking at cost effectiveness. People often ask me, for all the money going to a national screening program, is it worth it? And some modelling has cost, it does prove to be cost effective with a cost effectiveness ratio of $2,693 to $3,048. And really flagging the lower the number, the better for per life year saved. The fact that the fully implemented National Bowel Cancer Screening Program is estimated to reduce bowel cancer by 23% and, as stated last slide, reduce mortality by 36%. I just want to cover over the next few slides on early onset colorectal cancer. Why is bowel cancer in young Australians increasing? And for me, there's a link here to Feed Monday Lunch Live, and this is a presentation given by Dan Buchanan in June of last year. It's a fantastic presentation which goes through the pathophysiology, the population aspects, and some of the things they're looking at in terms of why younger Australians are being diagnosed with colorectal cancer, but also being missed in clinical practice. It is quite a topical feature. It was in 13th of February issue of Time, where Our Cancer Mystery. So there's a link on that if people want to read through the article in Time. So this is, again, acknowledging Dan Buchanan. I took a screenshot because I thought this was a really, really crucial slide just for me to have on my desktop. For me, just in America, early onset colorectal cancer is the #1 cause of cancer-related death in the US and second in women. We've also noticed an increased number of rectal cancers. We're not sure as to the reasons why. There's discussion on microplastics, but also processed food, but we're not 100% sure. And Dan Buchanan's team is looking at that at the moment at Peter Mac. But what you can see just on the right, I was really taken back by the graph on the right-hand side. As you can see, from 0 to 49, the incidence of colorectal cancer is rising. And you can see that steadily rising over the last 10, 15 years. As you can see, with the introduction of the bowel cancer screening program, for those over 65, given that patients have 10 more years to engage in the program, that there's been a drop in colorectal cancer presentations. Similarly, with in this case, with over 65, with mortality rates, as you can see, there's been a gentle and gradual decline in mortality rates. But as you can see, with the 49 or 0 to 49, the young adults and adults, that there's been a steep and some rising increase over the last 10 years. This is just a world map, and to see where it's all happening in terms of higher diagnosis of rates of people with bowel cancer at a young age. And they include Canada, America, also South America, parts of Europe, and that's particularly Western Europe, and as you can see, Australia and New Zealand. Australia is the highest incidence in the world. So this is the landing page for the National Bowel Cancer Screening Program. The link is just here if people want to use that link when they get a copy of the notes. But really, just to summarise, a really key feature of this website, they give you a phone number. So a patient can actually call a 1-800-627-701 and you get put through to an operator, and then you can then request a bowel cancer screening kit if you're eligible. If you don't want to talk to a person, you can actually fill out a web form. So a patient can go to the web form and complete those details. A very special, I guess, note just to make for the 45 to 49-year-old, they won't actually be sent any information or a toolkit to actually engage in the program. They must call up or complete the web form, or as we'll talk a little bit later, where a GP uses the alternative access route to organise the program through ordering a bulk sample of FOBT kits to give to our patients personally within our clinic. Just to pause, just for our primary care clinicians, doctors, managers, are we proactive in cancer screening in all our cancers, including colorectal cancer? If the participation rate is 40%, what can my clinic, everyone from managers, reception staff, nurses, allied health to clinicians, GPs, to increase this participant rate, and how we can encourage prevention and early detection in the 40 to 50-year-old age group of cancer and other conditions. The key fact is that post-COVID, CCV have indicated by the end of this decade, 2030, there will be 30,000 undiagnosed cancers in Victoria due to fall in screening rates post-COVID pandemic. And one of the key actions or levers we can push is through PHNs, using our clinician workforce to increase uptake engagement in screening programs. So just going to another web link, this is a special Australian government website, and it's guidance for patient screening. So this is from the Commonwealth, and it's guidance for patient screening. And on this page, it's got really useful information. It's got ability to get general practice packs, in terms of information, decision aids, pamphlets. So we really promote people in our waiting rooms being aware of our cancer screening programs. It also goes through your role encouraging cancer screening, the actual guidelines, although in this case you might not want to go to these guidelines, the fact that you're already using the health pathways. Staying up to date, and more cancer screening information is available through the Australian Commonwealth website. I'm now going through probably the more technical parts for practical 101 tips as a clinician. So it's going to be spread over two parts. Looking at how to engage through a medical program like best practice or medical director, and using the National Cancer Screening Registry. It is quite easy to set up and really easy to use. And for me, if you're not sure, for me, I hope there are some practice managers online who can actually, in this case, take time with their clinicians to really be on board with engaging in CSR through their medical electronic health records. The other way is through the website. It is quite clunky, takes a lot of steps, but I'll actually go through it for those who haven't got a software program to engage directly with the National Cancer Screening Registry. And where it's really important is it's crucial for GPs, because with the National Lung Cancer Registry and the National Lung Cancer Screening Program, we'll need to link ourselves in primary care in our clinics directly with the screening registry. So this is through best practice. These are some screenshots through my clinic and through some of the patient records that I've screenshotted. For me, when you actually pull up the patient, this comes up. This is for the bowel cancer screening. This is for a patient that has been someone I've been trying many years to convince to engage in bowel cancer screening. Obviously, as you can see, no activity has been, in this case, been taken for many years. And then going to, in this case, if you want to go to choose a form, and just on the previous slide, as you can see on the top right-hand side, there's a choose a form. And this is what you can see. The fact that through a number of options available to the GP, you can choose what is requested. Some of our kits, it's left in the garage or the laundry for 12 months. It might have expired, so you can order a replacement FOBT kit. In turn, you can actually get a bowel kit issued by a health provider, and that's where when we have our bulk ordered kits, a bowel practice, you'll need to enter those details because we'll need to inform the cancer registry that the patient has decided to pick up a kit from your clinic. We would prefer patients, in this case, did this way through the cancer registry rather than using external private pathology providers because the private providers aren't included in the cancer registry. So this is the alternative access pathway. This is through the healthcare portal. So you basically go through the Proto portal, which is here, and you click on this link and you'll get onto this next slide. This is where you need to have a whole lot of information to then identify the patient. And you need to put in the Medicare number, the family name, the giver name, sex, and then date of birth. There's a lot of cutting and pasting. So here, in terms of you're looking at IT and we can look at ease of use, we say this is probably clunky because there's like 6 data points you need to put in. So for me, that does take time. And for me, that's where the electronic health record access is so much more efficient and reliable. In terms, once you get to the patient, you can go into this form. You can have participant details. When you view, you'll actually see all the activities that's been undertaken by the patient, similar to what we saw just before with the best practice screenshot. You can also have FOBT results and summary in what has happened in the past, and that comes up also through the view function. So when you do choose a form, it was on that top right-hand side of the previous page. So once you choose a form, then you actually go to the bowel kit issued by the health provider. And this is very similar to what we did with the best practice example and the fact that you choose what is required. You can also, through your general practice, order what we call a FOBT GP access through a bulk order. Again, this is through the National Cancer Screening website, and that's through the Proto portal. And all you need to do from a practice management point of view or through the GP is through this icon or this button, and you click on that, and then you get the following slide, and then you start the order. Obviously, if you've got any concerns, you are able to order 100 kits while using the form. But if anyone that wants to order more than 100 forms, then you contact the 1800 627 701 number. There is a short training course you must do to order the bulk order format. Some practical tools. It's great to have a National Bowel Cancer Screening Program, but again, this is where primary care physicians, clinicians, management staff can play a crucial role to really make, in this case, an activity that patients will want to do and give reasons why. There are a number of patient barriers, and the patient may consider that doing the test is not a priority. I think one of the things is that being good clinicians using appropriate health literacy indicate to the patient that bowel cancer is the second highest cancer killer. If diagnosed early, it is, in this case, a good prognosis with really good treatments. The risk of cancer increases with age, but as we can see, younger people, so now those at 45, 49, an active discussion should be had about considering entering the National Bowel Cancer Screening at the age of 45, given the increases in early onset colorectal cancer. A common thing that the patients go, oh, it's in the laundry, it's in the garage. Some tips that might work is we'll say, we'll put it in the bathroom. For me, that's where having it near location, the increased uptake may occur. So it's such a time where they are likely to and are at home. So when your football players on the weekend, you're at home watching the football, make it a little timely reminder on your iPhone or on your on the fridge wall. I'm concerned about a cancer diagnosis. Inform the patient, as indicated before. Early detection does save lives, and we have very effective treatments, not only for stage 1 cancers, but stage 2, stage 3, given their 5-year mortality rates are all improving as well. Oh, it's a yucky test. The test is done, however, in the privacy of your home. For me, you do it at your time in your own space. So the fact that it's not as yucky as you can, in this case, envisage. And once it's done, the retention rates are much higher. And it's a simple test with a step-by-step guide. And if they even want a YouTube link, I'll show you a YouTube link on how to do the test. It's not that hard. And once they've seen the video, they'll actually engage in the process. This is the common one. It's like a medical student. I've lost a test on the tram. I've lost a test. It's too hard to order one. There are practical solutions. You can ask them, and this is what I do sometimes. I use BP and use the SMS message and give them the number and also the website link where they can also complete a form. You can use the alternative access pathway through best practice, through that portal that I showed you through best practice, or we actually do it on using the bulk KIP format where we actually give the sample and then register our patients through the National Cancer Registry. So I'll just play one video and just to show you that this actually comes not only in English, but also in other languages.
抗癌筛查可以挽救您的生命，如在早期发现，成功治愈率可达90%。50岁之后罹患肠癌的几率增加，因此
And I'll just go a little bit further.
之处，先排尿并冲洗坐便器，然后取出一张可冲掉的坐便器衬垫，铺在坐便器内存水的上方，这样可接取您的排便。在您排便之后，下一步是旋转绿色管盖，打开采集管，用与管盖连接的采集棒的顶部刮擦排便表面。
So I'll stop there. And even if you don't understand Mandarin, even the visuals have been designed specifically to make the understanding of doing the test quite easy. I guess just from a GP, we understand fully that general practice is a business. The fact that the management staff are acutely aware that we need to see patients. If we can't generate an income for the practice, there will be no doctors, no nurses. So this is being a little bit creative using MBS item numbers. And I also have been on the MBS Medicare task force looking at item numbers. And we do have a 45 to 49-year-old MBS assessment, and they're very similar to the over 75 assessments. For me, you can use a search engine, do a clinical audit, and call these patients in, because all we need is to undertake a chronic risk, looking at heart risk, looking at cancer risk. So, in this assessment, which needs to take half an hour to 45 minutes, we might get the nurse to do cardiovascular check, checking on the weight and also heart. We've got the need to take smoking and alcohol history check. We update the family history. Is there a family history of breast cancer, colorectal cancer, breast cancer, prostate cancer? Information regarding early onset colorectal cancer, 45 to 49, do they want to consider early engagement in the bowel cancer screening program? For our female patients, obviously, have a check on whether they're up to date with their cervical screening test. Breast screening, they want to participate in the breast screening early, but if not, obviously, to be ready at the age of 50. The male patient over 50, there's the PSA testing, informed consent. I'm pleased to announce that we're up to the final stages. The Daffodil Centre have been doing some work on PSA testing, modelling the role of active surveillance and MRIs, the fact that there'll be some, I think, updated information about over diagnosis of treatment, where there might be guidance from the college and from PCFA and the HMRC about a more better, in this case, survival rates and diagnostic rates in prostate cancer. I guess finally, just my final slide is that, we do have the National Lung Cancer Screening Program. It comes in July. It's only 4 months away. There'll be a marketing campaign for our patients, also information and education campaigns coming over the next 2 months. And I'm sure there'll be webinars such as this to really make sure we're on top of our 4th National Cancer Screening Program. So thank you. I'll stop the slides, and I hope I didn't go over time. Thank you.
Many thanks indeed, Associate Professor Zay. That was a fantastic overview of health pathways and the bowel cancer screening program. I think that's a great segue into our next speaker, John. And may I just also confirm in relation to the National Lung Cancer Screening Program, we've already had one webinar on that at North West Melbourne PHN, and we're planning to have about 3 prior to the rollout on the 1st of July. So Thank you very much indeed. And I'll now, without any further ado, hand over to John. And following John's presentation, my colleague Emma Saunders will take over and host Q&A and any questions that we may have. So many thanks. Thanks, John.
Thank you. Hello, everyone. Big thank you, first of all, to Justin and Marion for such fantastic presentations. And thanks to the team for inviting me to present today as well. Now, I'm going to provide an overview of the NCSR and an introduction to the functionality as well. And some of the functionality has been covered. Massive thank you, Justin. That makes my job a little bit easier. So first of all, I'd like to begin by acknowledging the traditional custodians of the land that I'm presenting from today, being the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present, and any Aboriginal and Torres Strait Islanders joining us today. Now, the National Cancer Screening Register, I'll refer to it as the NCSR, is a digital platform developed to underpin the Australian Government's National Cervical Screening Program and the National Bowel Cancer Screening Program. And as Justin touched on, we'll also be supporting the National Lung Cancer Screening Program from July as well. So it's designed to support the end-to-end operations of the programs to help achieve that shared goal that we all have of eliminating cervical cancer by 2035 as a public health issue and saving over 80,000 lives from bowel cancer by 2040 if we can increase the participation rate to 60%. Now, the key functions of the NCSR are to maximize participation, facilitate timely diagnosis, provide nationally consistent data and reporting, and create a connected digital ecosystem. And that's what I'll focus on for the most part today. Now, this slide shows how the NCSR supports connected care across the screening ecosystem, with the participant at the center of the NCSR. Essentially, we have a single record for each participant across all programs. And of course, that will include the lung screening program from July onwards. So we have a mail house to issue correspondence, including reminders via SMS as well. We've got the website where participants can submit forms and, as an example of one of those forms, order a bowel test kit directly to their home. We have a contact center taking around 6,000 calls a week and a portal for participants to check their last and next screening action, amongst other things, which is available via MyGov. And the NCSR has connections with Medicare for participant demographics and up-to-date contact details, the HI service or the Health Identifier service, as well as the provider directory service for healthcare provider details used for authentication. And data is accessible to authorised representatives within state and territory governments, federal government, and Australian Institute of Health and Welfare as well. And our digital channels and integrations are helping us to move away from the old days of having to call or fax the register or multiple labs, and provides that self-service way to access the information that you need. So what does the register actually do? So it's not simply a repository for all of that information like a cancer register or a clinical audit register. The NCSR manages operations for all the operations for the program. So we work with our mailhouse and Sonic to send out correspondence in the bowel test kits, and access to Medicare data enables identification of never screened participants. So participants can essentially be invited to screen. We send around 1 million pieces of correspondence each month. So once somebody has screened, we receive the results from the labs. And each month we receive around 150,000 CST results, around 8,000 cervical histology reports, which are then coded via clinical coders that sit under our health information managers. And we receive around 90,000 bowel program test kit results, which are directly ingested into the participant record. So we receive these results at the same time that they go back to yourselves, back to the provider. But usual workflows in general practice, of course, still occur, and the lab still sends the results to the nominated provider for the bowel program and the requesting provider for the cervical program. And those results are sent via the usual channels. So because the NCSR is also receiving the results, it can act as the safety net. So it takes those results and uses all that information held about their participant within their record to apply the correct screening pathway as per the clinical guidelines. This then updates the appropriate recommended next action and it issues the appropriate prompt, whether that's a letter or to the participant or to the healthcare provider or an SMS. Or even a phone call to a provider to understand if the participant has been referred to a specialist or essentially taken the next action on their pathway. And this is why receiving additional information from people like yourselves, either through the digital channels or via the contact center, is so important to make sure that the patient is on the right pathway and is receiving the appropriate follow-up. And this is why the programs have follow-up officers for the programs as well. So calling providers when we don't have all of that information that we need to update the pathway. And then essentially that national data set is available to AIHW, states and territories, and health to monitor clinical safety and is used to inform program policy. And by now, many of you will be familiar with the functionality and hopefully utilizing the register. So we have the two digital channels outlined by Justin. We've got the healthcare provider portal available within PRODA, and we've got integrations with best practice, medical director, and Communicare as well. And that's really the optimal functionality to utilize, because as Justin mentioned, when you go through the healthcare provider portal, you need to identify which patient it is and putting those identifiers before you can select the program and the record for that patient. Whereas with the integration, it does all of that authentication and checking in the background, taking the information that you've already got in the patient record. So within this functionality, you can access patients' bowel and cervical screening results and cervical screening histories online, view the next screening action, submit program forms electronically, manage patient details and preferences, including adding a nominated provider for the bowel program, and order bowel screening test kits as well. We've got around 3,800 practices that have integrated across Australia now with the register. So that's integrating either through best practice, medical director, or Communicare. And as that adoption increases, we're seeing more and more forms being submitted electronically, which is great to see. We've had about a 22% increase over the last 6 months. And we're seeing a huge move away from faxes, with a 94% reduction of fax cervical screening history requests. So we used to get around 8,000 faxed cervical screening history requests a month. That's gone down to about 270 a month. So it's a huge decrease. And it's essentially due to the fact that people can self-serve and get that information through their clinical information system or through the portal. So we're seeing an increase in people accessing cervical screening histories as well. So we used to get 8,000 faxed requests. Now we're seeing about 40,000 cervical screening histories accessed electronically through those digital channels each month. And for anyone that is yet to integrate with the system or wants to access the healthcare provider portal, we have a toolkit which should have all of the information that you need within it. So it focuses on the registration process and also how to get the most out of the functionality as well. So there are 2 slides for each of the different vendors. So showcasing how you register and how you set up in each of the different vendor systems. We've got lots and lots of videos on the Department of Health's YouTube channel as well, mostly focused on the healthcare provider portal. And within a couple of weeks, we'll have some very in-depth videos for each of the vendor systems as well. So really showcasing the full functionality that can be accessed through the integration. So if you have never registered to integrate your software, a bit of a heads up, you'll need your ABN details, your HPIO, and you'll need to be the responsible officer for the practice so that you can register that HPIO if you haven't already on PRODA. But we'll make sure that you get a link to this toolkit and you should have all the information you need. If not, or if you're struggling with that registration process, we also have an expert team that are available to help. So within this toolkit and on our website, there's a link to book in some time with one of our experts, and they can essentially hold your hand or walk you through that whole process and get you connected. And that registration is for integrating with your clinical system. It's a once-off registration, so you only need to do it that first time. And I'll also just take a couple of minutes to quickly walk through an example of what this looks like within best practice. So when we open up BP and we search for a patient record, that authentication and patient matching happens in the background. And if the patient is overdue for screening, this will be viewable in that notification banner and will come up in red text. So you can essentially just click on that particular line item to open up the NCSR hub. But if you just simply want to check the patient's screening record, you can go up to view and then click on the NCSR hub. So within the hub, we can see the patient's details as held in the NCSR. And we can click on that ellipses next to the Medicare number to update the participant's details held within the register, add a nominated healthcare provider, or add the patient's Aboriginal and Torres Strait Islander or country of origin status as well. We can then see alerts added to the patient's screening record, as well as the last and next screening action as per the clinical guidelines. We can also see all the results for the patient, including the patient's cervical screening history for the healthcare provider to access prior to actioning the next steps on the pathway for the patient. You can also have the ability to send information to the NCSR, which can be added directly onto the patient's record. Now, depending on the nature of what that information is and which form is being submitted, this can actually assist with the pathway recalculation, ensuring that the patient is on the correct screening pathway. Now, for this demonstration, we'll just use the request an FOBT kit as an example, and submitting the form triggers a new kit to be issued directly to the patient's address. And this is, of course, in addition to the alternative access to kits model that Justin referred to earlier. So, as I said, we'll have a few videos that will be released in a couple of weeks, showing all the functionality and most of the forms as well. But just wanted to give you a bit of a quick snapshot, and I will leave it there and hand back to Phil.
Many thanks, John. Wonderful presentation as always. Thank you for that overview of the Cancer Screening Registry and for the plug for general practices to integrate with the register. And what I'll do now is I'll hand over to my colleague Hannah from the ACPCC, and Hannah's going to help facilitate the Q&A session. And I think we've had a few questions, Hannah. So
yeah. We have. Thank you very much, Phil, and thanks to all the speakers. We have had a few questions come through, and I might, while we're with you, John, I might start with a few questions that have come through about the NCSR. The first one is about breast screening, and will breast screen join the NCSR platform?
That's an excellent question. So, of course, we are managing the operations in the register for the other 3 programs come July, but not for breast screen. Now, it's probably quite a historical thing. So, obviously, breast screen has been around since the early 90s, and they have very established processes and have a fantastic setup to be able to support women for breast screening. Now, of course, all screening programs follow the criteria as determined by the World Health Organization as what needs to happen to create a screening program, but they all operate really differently. So, as you know, for the Bowel program, we send the kits. Cervical program, you are aided by the healthcare provider, and for the breast screening program, it's radiology. So, in states and territories, they currently manage the screening programs. They manage the appointment system. They also manage local policy and the register and all aspects of the program, and do as I said, really fantastic job at that as well. So there's no plans to add the breast screening program to the NCSR.
Okay, thank you, John. The next question for you as well, and I hope this makes a bit more sense to you than it does to me, but it probably will. The question is there an audit check on data source errors and fixed?
Audit check and on source data errors. We have audits that we run every month, so pathway audits, and they're shared with the Department of Health and Aged Care federally in Canberra. I'm not sure if that answers the question.
And if the person who asked that question wanted to just post any clarification, please do so. I'll move on. We've got another question which is quite long, but just expressing some frustration that date of birth is not given out when people ring. You know, the question is about seeing large number of patients with English as a second language and similar names, and often with no address. Just wondered if you could comment on that as well, John.
Yeah, it can be quite tricky because, you know, as per the privacy and security requirements that we need to follow, we do have to ask for a number of identifiers. So minimum identifiers are an identifier like a Medicare number or a DVA number, surname, date of birth, sex, etc. And it can be slightly frustrating for people, and the main reason for that requirement is essentially so that we don't get a fuzzy match and we get an exact match with that patient, for the purposes of we don't want to make sure we don't add the wrong result to somebody's record or provide the wrong guidance to the healthcare provider there as well. So completely understand that it can be very frustrating, but there are reasons for some of those requirements, which I hope make sense.
Thank you. And Marion, did you have a comment on that as well?
Yeah, I've just read the question, and the participant might tell me if I'm wrong, but I think what she's saying is when they get a practitioner reminder, they have more than one patient in their practice with that name or a very similar name. So they're ringing the NCSR to say, is it this date of birth, that date of birth, or the other date of birth? So that they can figure out who it is in their system. So sounds like it might be something worth thinking about, John, because it might be sometimes privacy is always very important, but these are the practitioner that has been written to by the register. So being able to clarify which one of their patients the reminder relates to is, I think, what the person is asking about.
Ah, that makes sense. Thank you for reading that in detail.
The only solution I can think in 2 seconds from that stem, all our overseas students, and I think overseas students are given an example, and many of them are from countries where they have similar surnames. And being clinical dentists for many years, our overseas students, they don't have a Medicare number, but they access the system through private. They all have IHIs, so all of them should know their IHIs. And I believe the IHI is the unique identifier, so the practice can identify that patient. Would that be true?
We also have access to IHI, and that can be used as one of the identifiers. So yeah, absolutely. And if the register has issued a letter to the provider about a particular patient, it should also have the register reference number on it, which can be used when calling the contact center.
Okay, great. Thank you. Thank you, John and Justin and Marion, for your input into that as well. I might move on to a question for Marion. The question is about people who were exposed to DES in utero, and these people have annual co-testing and colposcopic assessment indefinitely, do they still need to do that if they have had a hysterectomy?
Yes, they do. And the reason is, well, firstly, this cohort, the last DES was being prescribed in the early 1970s. So give us another decade or so, and most of these patients will age out of screening. And DES was a terribly shameful sort of situation. I think we all know that. But the actual risk associated with DES is clear cell carcinomas, particularly of the vagina, can affect the cervix. So those colposcopic assessments annually are of the cervix and vagina, at which point the co-test can be taken. And typically that's done by a specialist and a super specialist in vaginal disease. So, you know, I can think of the one person in Melbourne who everyone I know would send patients to. And so this is a very small group, but it's not just the cervix that's at risk. It's also the vagina, and these are nasty cancers. So that remains the guidance in the national guidelines.
Thank you. While we're with you, Marion, another question for you on that move from co-testing for Testacure to HPV testing. The question is, can you provide some more information on the evidence behind the change, and specifically how we can be reassured that the change is safe for our patients who've been treated for HSIL?
So you'll find that evidence actually in the guidelines, but essentially there are several longitudinal studies looking at people who have been treated for HSIL, and in particular the longitudinal studies at Kaiser Permanente, who is a big service in Northern California. It's an insurance led health service with very, very good data. And we can see over time the protection that the negative HPV test is affording. So, and if you want the references, you will find it backed up on Magic App.
Great, thank you. I might move on to a couple of questions for Justin now. Justin, we've got a question about the question is, I have some patients older than 74 years old and they want to continue the FOBT screening process. What is the best option available to them?
Yeah, so as you know, the program's for 45 to 74-year-olds, so they won't be eligible to participate in the National Bowel Cancer Screening Program. I'll probably take it on two fronts. One, you need to know the patient well, know their past history. There's no point doing an FOBT after 75 if, let's say, they've got multiple issues: diabetes, heart disease, emphysema. However, many of our patients are living. My oldest patient is 95. I've just seen a 99-year-old the other day. Amazing health. Now, I'm not saying we would do FOBT for a 99-year-old, but the fact that at 74, if there's a good chance of them being at a good health in 5 years' time, I'd certainly do an FOBT, but do it through a private pathology service.
Okay, great. Also, another question for you, Justin, is about the use of aspirin in the bowel screening program. Can you provide some more information on the recommendations around the use of aspirin?
Yeah, so it was known, aspirin, obviously we know from evidence and from journal articles, very good for heart protection. There's been some literature over the last 5-10 years that aspirin isn't seen to be a bowel cancer protectant. So for me, it's not really, in speaking to my specialist colleagues, it's not something that's mentioned as a way to prevent bowel cancer. I think the best way to, I guess in my role to CCB, we look at prevention as well. It's just exercise, watch your weight, try not to be over 100 kilos. That's the main things. It's about prevention rather than taking medication, active lifestyle.
Okay, great, thank you. And also, while we're with you, Justin, you mentioned the low uptake of the bowel screening program and the higher uptakes of some of our other cancer screening programs. What do you think we can learn from the other programs that we can apply to the bowel program to get that participation level up?
I think just my personal experience is that our women patients, they already know about screening from 25. So there is this active activity, engagement, close relationship with the GP. As you know, women do see GPs more than men. So obviously then they engage in the breast cancer screening, and a bit like the colorectal bowel cancer screening program. Once you do one, the retention rate's really high. I think that's where, first of all, take opportunities with our male patients, starting screening consultations early, not at 45, but at 30. Really doing it early. Saying in 10 years' time, you need to consider this and that. I guess the second thing is, I really think our clinicians in clinical care, our practice managers, our nurses can be really team oriented and be creative. I've got a medical student doing an audit at the moment on smoking history. In 1 month of general practice, 800 patients, or 1 week of a general practice, 800 patients were seen, 56 smokers, of which only 20 could be calculated with pack years. So for me, this is where, as a practice, we're going to look at some proactive things in the waning area, getting obviously posters up. I think we've got to use a range of things, not only just in the consult room, but also in our waiting areas and with our reception and nursing team to promote screening.
Mm-hmm. Is there any options for people under the age of 45? If this is something they're worried about. You talked a lot about the incidence of early onset bowel cancer in those younger age groups. I'm sure you've all seen instances and cases of patients who are much younger than 45 who've had a bowel cancer diagnosis. Do you have any sort of guidance around that age group, or people who might present with particular concerns or worries?
Yeah, so for me, I think the research that John Emery and myself are doing, and you'll see in the optimal care pathway, we're just doing an update of the colorectal cancer pathway. I think it's not asymptomatic, but people with, let's say 25, 28, male, female, no red flag symptoms like loss of weight, anemia, but non-specific bloating, abdominal pain. We can see that they're the early signs to actually look at an FOBT. Have a look, and in the end, it's negative, fine. If there's ongoing symptoms, going for a colonoscopy. I think that's where, with our early onset colorectal cancer, if anyone's got symptoms, just don't say it's nothing, and say, oh, I think it's irritable bowel syndrome, or you just got a migrainous abdominal pain. You got to actually think about colorectal cancer at this age group.
Okay, great. Yeah, thank you. That's some excellent advice. I'm just going to go back to Marion. We have another question about a patient who has had a hysterectomy for endometrial cancer. Do they need to have HPV tests yearly?
So not because of the endometrial cancer, of course, but that will depend on the patient's screening history, and on the findings at hysterectomy. So if there's no abnormalities in the cervix at hysterectomy and the patient has ever participated in the program, they don't need anything. And if they haven't completed test of cure, or they've never participated in screening, they may need 2 HPV tests until a year apart, until both are negative. So they don't need to keep going annually forever, but just that post-hysterectomy testing would apply in that situation.
Fantastic. Thank you very much, Marion, and thank you to all our presenters. We are coming up to time, to 8 o'clock, so we will need to finish our Q&A session there. I'm sorry to the people whose questions that we didn't get to. I wanted to thank all the presenters. A huge thank you from us at the Victorian Cancer Screening Framework Partnership, as well as the PHN, for being involved in tonight's webinar. This has been recorded, so you will all get a link to the recording, as well as a post-webinar email which will link you to lots of the resources that we have mentioned throughout. So I would like to thank you all for joining tonight as well. We really would love to get your feedback on tonight's session. Hopefully you can see that QR code up on your screen now. There'll also be a link posted in the chat. So please very strongly encourage you to get on there and complete the evaluation questionnaire. There'll also be a question on there which asks you what else you would like to see at these future webinars in the cancer screening space. So please let us know because that will help to inform our future sessions. So thanks again to all our presenters and thank you to joining us tonight. I'm going to leave that QR code up on the screen for a moment so you can access the evaluation survey, and we hope to see you all again at our next webinar, which will be coming up in June, and we'll provide some more details for that in the coming months. So thank you again and have a lovely evening.